level. Now, to support this product, there are a number of things you have to do. The first is communication is really important. We do have a couple of customers on this, and they spent a lot of time communicating this. In order to make this work, you have to have both Tier 1 and Tier 3. You can't just pick Tier 1, because that feels good. If you want, we said in the market to the 5 plans, don't break Tier 3 off of Tier 1. We all committed to that. And don't change Tier 3. You got to have both. It's really important to stay to nationally accepted and recognized preference supply sensitive services if you're going to grow this. If you want to add more, we could have gone, we've thought about C-sections. But, you know, dealing with women's reproductive rights is a really tough one, and we didn't want to go there. But C-sections were another one that we thought about putting into the Tier 3. If you offer this as an option to your employees, the employees need to see the savings in that, either in their premium share or some other way. So if this is an option, this should be the lowest cost option, and it should be either fully funded by the employer or with very limited premium exposure. In other words, this can't be all about saving employers' money. You got to pass some of that on to the employee who takes this product. And for some people, and I'll tell you, we've got a couple of clients who've modified it already. Tier 3 may be a little too bold. There's other ways to do it. For example, the state of Oregon and the Oregon Educators Benefit Board, another large aggregation of teachers in our state, have adopted the Tier 3 benefit, but they've adopted it at a $500 fixed copay for about 70% of the services. They did not put hysterectomies in there, for example. They didn't want to go there. So you can modify it, but you don't get as much of a savings, right? Now, market interest. It turns out that this Evraz Steel has purchased this for Jan 1. They used to be Oregon Steel Mills, thank you, Mary, in McMinnville. ODS Health Plan is put this in place for their employees. They like it. They're also one of the carriers that are participating. The state of Oregon has adopted this, as has PERS, not PERS, the Oregon Educator Benefit Board. And we're beginning to get a little experience about it, and I'll talk about that. It is gaining interest. Focus groups have been done. There was a woman by the name of Carol Foley who does some wonderful research. She did a lot of focus groups, and actually the interest level is gaining. People are nervous about Tier 3, and we'll talk about the cultural challenges in that. But our feedback from the payers is that they're showing it more, and more of employers are beginning to wonder if this isn't a better mousetrap. The guy at Evraz Steel who pushed this is on the Oregon Business Council, and he took the plan for himself and his family. He liked it, and he made a big splash about that. One leader makes a difference. And also, as you know, the national interest in value-based insurance design is really growing. And I've done this talk to some national groups. And generally speaking, I see employers that are kind of going, you know, I like this. Purdue Chicken, the Purdue chicken guy, they have bought a similar product. Who would have thunk it, you know? The chicken people like this. All right. Is it Frank Purdue? Frank, yeah. An interesting guy. Now, the early learnings. There are some learnings. And the early learnings are that everybody loves Tier 1. Okay, yeah, got that. Tier 3 has some concerns with a lot of stakeholders. And this is all about the common good versus a focus on individuals. There is this sense amongst HR executives that people that are experiencing a Tier 3 service are already in a vulnerable place. And do we really want to make them even more vulnerable by asking them to pay more for a service? And that's a very important concern. This is not for the weak of heart. This product's not for the weak of heart. This is a population health-driven product. And no matter how many times you say to somebody, yeah, there might be 1 or 2 people that might be somewhat injured by this financially, although there's cost, you know, there's maximum out of pocket on this. it's very hard to get Americans to understand what the Scandinavians have understood for a long time, and most Europeans, which is we're in the business of doing the most good for the most people, at least at not cost. That's a cultural norm here. It's not in our country. If it was, we'd have a very different set of Medicare benefits than we do now, but nobody wants to take that on. Now, in Oregon, with the Medicaid experiment 20 years ago, this became more available and more accepted, mostly because physicians, it turns out that doctors really like prioritized services because it makes it very easy for them to look their patient in the eye and simply say, this is not a covered service, ma'am, because it doesn't offer as much clinical value as the ones above it. But this is a tough one, this common good versus a focus on individuals, and I would say we're not there yet. Shared decision-making tools. Having, whether it's Wenberg's Dialogue, Health Dialogue, which are very expensive but very good, or the CareWise, HealthWise products, it turns out having shared decision-making tools available to help educate the members about these Tier 3 services is a very useful product, and in our plan we're making that available. Some people are softening the Tier 3 benefit. They're mostly self-insured folks who are doing that. And one leader makes a difference. That's a big learning. There's this fellow at Everest Steel, John Worster, who's quoted in a couple of articles. He just loved this thing, and he bought it. He bought it for himself, and he pushed it hard. Now, what's the next steps? And I'm getting to the end here. The next steps are that the plans will continue to kind of evolve this design. We only have a few employers now. We're going to continue to learn how to communicate this better. We're going to look at these shared decision-making tools and make sure we're landing on ones that really work, because they're not all the same caliber. We're going to work with state policy to try to expand this, and in our state, the Oregon Health Authority has been charged with designing a value-based benefit design for its state employees further down the road. I think that's coming. John Kitzhaber is back in the is our governor again, and he has an orientation toward this kind of thinking, right? We're going to evaluate the membership once we have enough of it to see if it's credible. Well, what we want to know is it growing? What's the trend rate on this versus a reference plan? Utilization, quality metrics, et cetera, et cetera. Now, let me end this talk with just 3 slides from a presentation that is coming to the Oregon Health Leadership Council, this group of leaders. And I even used their logo because I think what's interesting is that the Leadership Council, this is the health leadership in the state of Oregon, is agreeing now to a number of things that I don't think they would have agreed to if not for this task force. This group has agreed that the goal for per capita cost increases in healthcare in Oregon is 4.5%. 4.5% total spend. Now, will this mean that they reduce their unit price increases next year to achieve this? That is unknown at this point. But there is a document that now says you agreed in principle to per capita spending increases of 4.5%. You're part of that. If trend is 2 to 3%, then unit price has to be something like that too to get those numbers done. And that's without benefit buy down. There's a lot of talk about HEDIS population improvement in this group and CAHPS, right? Let's go to the next slide. We're going to start measuring at the aggregate level in this task force in front of our customers average annual growth in per capita expenditure. We're going to look at total PMPM cost by commercial, Medicare, and Medicaid. We're going to get per capita medical expenditures, I mentioned that, and we're going to look at medical inflation rates that are filed with DCBS for small group. The point is the black box in healthcare is going away in our state, and we're going to get much more transparent as a group about where the cost drivers are. Either unit price, hospital increases, specialty physician excess utilization, whatever it is, it's going to be shared in front of large customers with most of the healthcare leadership in a room, and that's a good thing. And that's, I think, the most positive thing that's come out of this work. And finally, we're going to look at some areas to track, ED utilization, commercial Medicare, Medicaid. You can read all this. Readmission rates. We're going to look at ambulatory care sensitive conditions to see how well our industry in Oregon is managing people who don't have to be in the hospital, right? So all of this and I'll just end with that, you know, all of this work has been, I think, in service to making healthcare more transparent and making performance and the challenges a lot more transparent in a more collaborative way. It's unknown yet whether or not this will have a positive impact on our commercial premium trends into the new future, but this is better than the old way. My only you know, advice to you, for those of you that want to pursue this, is you need to find some leaders who are passionate about this topic. And it was very helpful to find a large employer who looks people in the eye and says to the healthcare community in total, shame on you for these practices that continue to drive healthcare costs to a place where my middle-class average employee cannot even use the health insurance that we are purchasing for them. Get them all in a room and have an honest dialogue and turn it from part of you're the problem to you help us be part of the solution. And I think it produces a much more collaborative spirit, and I'm beginning to see real changes on the part of the delivery systems to begin to live within their limits. So with that, Mary, I'm going to just open it up to some questions and hope that this is what you were hoping for.
Yep.